Good morning. My name is Dr. Clement Mnuka, and today I would like to talk about viruses I have never, spoke about before. The enteroviruses. Enteroviruses, there are only three of them that I know of. The Coxsackie virus, the ecovirus, and the poliovirus. And today, I'd like to put more emphasis on the poliovirus, because these two, the Coxsackie virus and the ecovirus, they develop into conditions that form a syndrome known as hepangina. Hepangina doesn't take us anywhere. I mean, it's not what I would like to talk about. What I would be interested in talking about, in fact, I was motivated to talk about this when I saw a patient. Hey, man, a patient with poliomyelitis. In other words, poliomyelitis is the inflammation of the spinal cord infected by this poliovirus. So there are three of them, these enteroviruses. We say Coxsackie, ecovirus, and then the poliovirus. The reason why I'm mentioning the other two is because when you want to diagnose poliovirus, when you want to diagnose poliomyelitis, you've got to isolate this poliovirus. You've got to say, yes, there's a poliovirus. But because it's an enterovirus, it mixes with these two, and they share the same location, that is the gastrointestinal tract. They enter the body using this fecal oral contamination, and also the oropharyngeal secretions. Because the oropharyngeal secretions, and the gastrointestinal, why are we worried about this? It is because they are synthesized in this oropharyngeal area, oropharynx, and the gastrointestinal tract. So those are the cells which actually are hosts of poliovirus. Remember, all viruses are obligate parasites. In other words, they can't make their own proteins and reproduce themselves. They can't do that. They need a host cell. They need a host to do that, to synthesize the viral proteins so that it can end up having copies of itself. In other words, replicating. So the oropharynx is important in that area. The gastrointestinal tract is important because the host cells are there to make, to interpret, because they actually have ribosomes which actually interpret the mRNA, the messenger RNA. All viruses have to gravitate to a messenger RNA so that these can be interpreted by the host viruses, the host cells, because they've got ribosomes, they can actually interpret and say, oh, it should be this viral protein, it should be this viral protein, that kind of thing. So this is what is happening. This is what is happening. This is now, you have this poliovirus, which causes poliomyelitis. There are 3 antigenically different forms of poliovirus. It's serotype 1, serotype 2, serotype 3. Serotype 1, serotype 2, serotype 3. They're antigenically different. The antigens are different. But they all cause poliomyelitis. So, why are we worried about poliomyelitis? Because poliomyelitis can actually move from an inapparent form, subclinical form, to a fatal poliomyelitis. It's a fatal paralytic one. And that's the reason why we are talking about this. And at times, depending on the extent of paralysis, they can deform a patient. Hey, man, I've seen it with a young boy. I don't know why it's the prevalence of this is in boys. Okay, paralysis, for instance, boys get paralyzed when the girls don't actually get paralyzed, and even the elders, they don't get actually paralyzed. Okay, of course, they will suffer from the condition, but they don't get to the extent of paralysis. The paralysis tends to be prevalent with boys. I don't have an idea why that happens. And this is a boy that I'm talking about. This is my patient who motivated me to do this, to give this presentation. The extent of paralysis is determined by the location. Where is the lesion? Is it in the cervical area, that is the neck? Is it in the thorax? Or is it in the, the lumbar puncture? The lumbar area? Is it in the lumbar area? If it's in the lumbar area, man, my patient walks in a very clumsy fashion because the lesion is in the lumbar area. So that twisted walk, it's so clumsy, amazingly so. And this developed when he was young. He got infected when he was a baby. These patients, they get infected in the oropharynx and the gastrointestinal tract. And then when it is there, it is now ready for spreading. It goes to the regional lymph nodes. And the regional lymph nodes, what does it do? It goes straight to the blood. And that's when it's highly probable now to get a paralysis, because it will go until it gets to the nervous system, and that's where paralysis takes place. So this is the problem. So there are factors which actually influence this paralysis. Like, for instance, a localized trauma. What example do I have of a localized trauma? Tonsillectomy. Inoculation. Anything that will make sure, pregnancy, anything that will make sure that there's transference of this poliovirus into the blood so that it can move around the blood until it gets to the nervous system. So the probability of infection or of paralysis There are factors which influence that. Pregnancy, localized trauma, tonsillectomy, tooth extraction, anything that makes sure that blood is involved so that, blood will be able to move around and spread this until it gets to the nervous system. Men, I'd like to stop just here and say something about, is there a way of preventing this? Yes, there is a way. Dr. Salk, for instance, developed a way, a vaccine with all these seroforms that I was talking about, 01, 02, 03. What he did, he used, dead viruses. How did he do that? They were eliminated. They were inactivated. And so they're dead. So then these appeal to the immune system, and the immune system will see this and synthesize antibodies against poliomyelitis or against poliovirus. And this has worked wonders to prevent polio, to prevent the spread of poliovirus. Is that all? That's called the Salk vaccine, because it was developed by Dr. Salk, Dr. Jonas Salk. But there is the Sabin one. The Sabin one is different from the Salk. Salk, they are dead viruses. The immune system is reacting to dead viruses and then make antibodies against the virus. And that is good. But now, there's a better one, the Sabin one. The Sabin one. The viruses are not dead. The viruses are alive. Live viruses. But weakened so that they don't hurt the patient. They don't cause poliomyelitis. They are weakened so that the body should react to this. In the immune system should react to form antibodies, and it tends to form better antibodies than the Salk. So the one that is being used today is the Sabin virus. They call it the Sabin virus. This is a vaccine. They call it Sabin vaccine. Because Sabin, we're talking of live, weakened viruses. The immune system is reacting to this. It's immunogenic. They are immunogenic, and they're very good in that they produce antibodies and, good amounts of antibodies. But these, because of the risk of infecting, whoever gets a Sabin vaccine, we have to check the immunity of whoever is getting it. If a patient is immunodeficient, like HIV-infected patients, you do not give the Sabin virus. You don't even want people who are getting, it's an oral virus actually, they call it a trivalent, a trivalent oral polio vaccine. Polio vaccine. It's oral, you take it orally. Unlike the first one that's injected, you take it orally. It's unlike the Salk. So when you take this oral one, in fact, it's trivalent and even monovalent. But the monovalent one is also this good, but only if you know the serotype. If you don't know the serotype, it's unwise to use the monovalent one. That is the sabin one that is monovalent. It can be trivalent or monovalent. So the trivalent one is the best to give because you are catering for all serotypes. Remember I said there are 3 serotypes. Serotype 1, serotype 2, serotype 3. They are antigenically different, right? And that is why then you have to make sure that you give the trivalent one. But make sure that the patient is not old. Old people, they tend to lose their immune system. So you're not going to give the trivalent one, in other words, the trivalent oral polio vaccine. You're not going to give that one to the elderly and even with pregnant ladies, we do give it. Pregnant ladies, we don't have a problem. You don't have a problem. But you don't give it with immunodeficient people who are taking corticosteroids, people who are taking cancer therapy, people who are taking, anything that is immunocompromising. You don't want the top vaccine, the trivalent one. You don't want the trivalent oral polio vaccine. You don't want to give it to those because it might hurt them. You must remember, they don't have the immune system that you are boasting of, that you as a healthy young person you have. No, they don't have that. And because of that, don't give it to the elderly. Don't give it to immunodeficient patients, like HIV infected patients. You don't give it, Make sure that the immunodeficiency of the patient is well defined and it is known that this is this, and therefore you can give drug. We say even the immunocompromised patients, they must be away from the people who have just received the top. In other words, the trivalent oral polio vaccine. People who have just received it, they must be away for something like 2 weeks from the people who are immunocompromised because they can get it from you. Literally, from you, the contact and everything, they can get it from you. So you don't want to transfer this live vaccine. You don't want to transfer these live viruses to the patient who's immunocompromised. So this is something very important to understand, so that you don't have a problem of having to infect a patient who was in fact not infected. It's just that the immunocompromisation of this particular patient is now the determining factor. Thanks.